And and with that, we can dive right in. My name is Pamela Bialik, Policy Analyst at CRPO. Today, we'll be discussing medical assistance in dying, also known as MAiD. To begin, we'd like to start with the land acknowledgement. Of course, the viewers of this webinar are spread across Ontario and potentially beyond, but the CRPO offices are physically located in Toronto or Tekaronto, so the acknowledgement will be focused on that area. We acknowledge the land we are virtually meeting from is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We also want to encourage everyone to do some research on the land they reside on and learn about the unique history of their region. As we begin this webinar, we do want to acknowledge that for many people, MAiD is an emotionally charged and deeply complex matter, and we want to note that we aren't aiming to change any opinions. Today, we are looking to inform registrants about the MAiD process so that they can better serve their clients and remind registrants of their responsibilities when working with clients who may be pursuing MAiD or working alongside their loved ones. You'll also note that at the bottom of most slides, there is a linked citation. Once the slides have been distributed, you can click on these links to read information from government sources. First, to clarify, medical assistance in dying, also known as MAiD, is a process that allows someone who is found eligible to be able to receive assistance from a medical practitioner in ending their life. The Federal Criminal Code of Canada permits this to take place only under very specific circumstances and rules. Anyone requesting this service must meet specific eligibility criteria to receive medical assistance in dying. Any medical practitioner who administers an assisted death to someone must satisfy certain safeguards first. There are currently two avenues for seeking MAiD. Track 1 is for individuals where natural death is reasonably foreseeable, while Track 2 is for cases where natural death is not reasonably foreseeable. Now, you might be wondering what the official process looks like in broad strokes. Because MAiD is a medical process, it is best for a client to discuss the process and any nuanced questions with medical practitioners, although they may choose to discuss their feelings, concerns, and questions about the matter with a trusted professional, like an RP, first. This process generally opens through conversations with one's primary care team. If a primary care provider is not comfortable providing or assessing eligibility for MAiD, they may refer to another practitioner. In Ontario, if a client does not have a doctor or nurse practitioner, they may wish to contact Ontario's Care Coordination Service, which can provide individuals, caregivers, and providers with information about MAiD and services and other end-of-life options, as well as referrals for MAiD services. It does accept self-referrals and can connect clients with a dedicated physician or nurse practitioner who can act as MAiD assessors and providers. The process for MAiD generally includes the following major steps: a written request from the individual seeking MAiD, which has been witnessed, two formal eligibility assessments from physicians or nurse practitioners. Before MAiD can be provided, the provider must confirm all safeguards are being met. And finally, assuming the client is approved for MAiD and all relevant safeguards have been met, the next step would be the provision of MAiD. Now, in order to be eligible for MAiD, an individual must be eligible for healthcare services funded by a province or territory or the federal government. Clients may also be eligible if they meet the province or territory's minimum period of residence or waiting period. Individuals must be at least 18 years old and mentally competent, which means being capable to make informed healthcare decisions. Individuals must have a grievous and irremediable medical condition. This means medical conditions that are all of the following: are a serious illness, disease, or disability that are causing an advanced state of decline that can't be reversed and that cause unbearable physical or mental suffering that cannot be relieved under acceptable conditions. Additionally, an individual must also make a voluntary request for medical assistance in dying, which cannot be the result of outside pressure or influence. Finally, an individual must be able to give informed consent to receive medical assistance in dying. And just as a reminder, as some people joined a few minutes late, you can pose questions through the Q&A function in Zoom today, as staff will be monitoring throughout the discussion. In addition to firm eligibility criteria, there are a series of additional safeguards in place for individuals pursuing MAiD that providers must ensure are being met. I'll start with the criteria that is relevant to both Track 1, where natural death is reasonably foreseeable, and Track 2, where natural death is not reasonably foreseeable. As noted, two independent eligible healthcare practitioners, in Ontario, that means physicians or nurse practitioners, must confirm eligibility. Additionally, a formal written request must be made and witnessed. The person seeking MAiD must also be informed that they can withdraw consent at any point in time, and they must also be given the opportunity to withdraw consent immediately before receiving MAiD. They must also provide express consent prior to the provision of MAiD, although in some circumstances this condition can be waived. Now, for track 2, there are some additional requirements on top of everything we just went over. Just as before, two independent doctors or nurse practitioners must provide the assessments. However, if neither of those two practitioners who assess eligibility has specific expertise in the condition that is causing the person suffering, they must consult with a person who has such expertise. Additionally, as part of the informed consent process, alternatives to MAiD must be identified to the person seeking MAiD and consultations offered. These alternatives may include palliative care, social supports, or counseling. Additionally, the individual seeking MAiD and their assessors must have discussed reasonable and available means to alleviate suffering and agree that serious consideration has been given to those means. It is not a requirement that the individual seeking MAiD pursue any of those options. Finally, at least 90 days must have elapsed between the beginning of the assessment period and the provision of MAiD, although this waiting period can be waived in very specific circumstances in which an individual is expected to lose capacity. Again, these are in addition to the safeguards we initially discussed. After all those steps, provided an individual is found to be eligible and all safeguards have been met, the provision of MAiD is the next step. Before the provision of MAiD, an individual will have a final opportunity to withdraw consent and must confirm express consent subject to the limited exception about loss of capacity. Assuming they choose to go ahead with the procedure, there are two options for the provision of MAiD: direct administration of a substance that causes death by an eligible healthcare practitioner, or receiving a prescription or substance that can be self-administered to cause death. It's our understanding that the former is much more common than the latter. Now, as you all know, when signing up for this webinar, you were given an opportunity to ask some questions, and we've done our best to answer the ones that were most commonly asked. First, we were asked about whether or not it's appropriate for an RP to proactively bring up the topic of MAiD. There are a number of considerations at play here. First, you need to consider your own competence. Are you fluent enough in the topic to discuss it and answer questions so that the client has an accurate and informed understanding? It's also important to employ safe and effective use of self to ensure you aren't unduly influencing a client's decision. There's the chance it could be interpreted as a suggestion to pursue rather than being shared for informative purposes. Finally, you would have to be clear that they need to talk with a medical professional or their care provider about the medical aspects and alternatives. We were also asked if an RP can be present for the provision of MAiD if requested by a client. An RP being present may constitute a boundary crossing. However, boundary crossings can be helpful in some scenarios. It is up to individual RPs to determine whether it would be appropriate to attend the provision of MAiD based on their request and the therapeutic relationship with the client. The question of whether or not people suffering from mental illness, if that is the sole underlying condition, are eligible for MAiD came in as well. The answer is no, not currently. This option has been legislatively delayed until March 2027, although we do understand a charter challenge has been launched in response to the delay, so that timeline may change. However, we do want to note that clients struggling with their mental health, in addition to meeting the established eligibility criteria, would be eligible for MAiD. Finally, there are some questions about countertransference and influencing the direction of treatment. As always, RPs are expected to employ safe and effective use of self when working with clients pursuing MAiD or their loved ones and support autonomy of persons. RPs should not impose their own beliefs about MAiD onto the client or those who have a loved one pursuing MAiD. If a registrant is struggling with safe and effective use of self or their feelings about a client pursuing MAiD, we would suggest seeking consultation or seeking supervision. Now, should an RP choose to, there are a number of ways to participate in the MAiD process, both officially and unofficially. First, RPs and other paid healthcare professionals may act as an independent witness to the formal written request for MAiD, provided they do not benefit from the death, act as an unpaid caregiver to the applicant, or be an owner or operator of a healthcare facility where the applicant lives or is receiving care. The witness must also understand what it means to request medical assistance in dying. The second way RPs may wish to engage in the process is by supporting decision makers and formal assessors. RPs are not one of the professionals able to approve MAiD requests. However, they can support decision makers. Some institutions and providers have created consultation tables or consultation dyads that allow other professionals to share opinions and feedback with the assessor. While the ultimate decision will remain with the primary assessor, RPs can assist the assessor in conversations with the applicant and provide opinions about topics within their scope of practice. Finally, and the most likely point of contact between RPs and MAiD is through supporting clients in session. Clients of RPs may be seeking MAiD through either track and may wish to discuss their thoughts and feelings about medically ending their life during sessions. As always, all standards are applicable when working with clients, including those pursuing MAiD or their loved ones. However, we wanted to highlight a few in particular that stand out. As noted in Standard 1.8, registrants are prohibited from unduly influencing clients in personal decisions. This prohibition extends to influencing client decisions regarding MAiD. Discussions with clients should be informative and outcome neutral without the registrant suggesting or projecting preferred or potential outcomes onto the client. Employing safe and effective use of self is paramount in these scenarios. Registrants must be careful not to impose their own opinions or beliefs about MAiD onto the client. Registrants should also be aware that it is a criminal offense in Canada to counsel a person to die by suicide. However, healthcare professionals providing information to a person on the lawful provision of medical assistance in dying are not considered to be counseling a person to die by suicide. Under Standard 2.1, registrants are required to only provide services within their knowledge, skill, and judgment, or their competence, and understand their professional capabilities. Members are urged to ensure their competence, which includes possessing knowledge about the legislation as well as the roles, responsibilities, and limitations of RPs, identifying their own values and attitudes to ensure they do not adversely affect clients, and seeking consultation as needed. Additionally, under 3.1, we'd like to remind you that MAiD intention is not a mandatory reporting obligation, and as a result, there is no obligation to breach confidentiality when a client discusses an intention to pursue MAiD. In fact, reporting a client in such cases could be considered a serious breach of confidentiality. In cases where a client discloses that they have not and do not intend to discuss their decision to pursue MAiD with loved ones, a registrant may wish to enter into a conversation regarding the apprehension, but it is not the role of the RP to breach confidentiality. Under Standard 3.3, it's important that registrants remember their obligation for communicating client care. It is possible that a provider of MAiD may reach out for additional information on the client in question. This is known as collateral information, which is defined as information provided about a person by the person's treating team, family members, or significant contacts. In these scenarios, as always, it's best to discuss the request for disclosure directly with the client, even if the MAiD provider relays the consent of the client. We'd also like to remind registrants that personal opinion about MAiD would not be considered a sufficient reason to prevent information sharing. Finally, under Section 5.1 of the standards, we'd like to remind registrants of their responsibility to maintain up-to-date records of conversations with clients, and this includes documenting discussions about MAiD. I'm not going to go over everything you see on the screen right now, but we have collected some resources that you may wish to look at for further information or guidance. These are all linked and you can access them further once we distribute the slides. Now, here to talk to us a little bit more about working with clients seeking MAiD and their loved ones is Andrea Warnick and Colleen Mousseau from AWC Grief Support. Andrea is a registered psychotherapist and registered nurse whose passion lies in helping individuals, families, and communities support people of all ages who are grieving an illness or death in their lives. With years of nursing and counseling experience both in Canada and abroad, and a master's degree in thanatology, which is the study of dying and death, Andrea brings to her work a rare mixture of medical and psychosocial expertise. Andrea developed and teaches the 5-day certificate program in children's grief and bereavement at Sick Kids Center for Community Mental Health. She was also the lead content developer for kidsgrief.ca and Kids Grief for Educators. Once a month, Andrea hosts a free forum through Canadian Virtual Hospice, Kids Grief Q&A, where she responds to questions from families and professionals from across the country about supporting grieving children and youth. Andrea lives in Guelph, Ontario, from where she and Colleen lead AWC Grief Support, a group practice of over 30 therapists who provide grief therapy across Ontario and grief consultation and education across Canada. Colleen is a registered psychotherapist, a servant leader, and builder of strong teams. With over 25 years of experience in developmental and community mental health agencies across Ontario, she is skilled at providing direct grief and trauma support to people of all ages. In addition to her clinical work, Colleen offers clinical consultation and grief and trauma education to professionals, both individually and in large groups. In her role at AWC, Colleen provides clinical support to the team while passionately advocating for the inclusion of all individuals in addressing the mental health needs of children, youth, adolescents, and adults who are neurodiverse. Her commitment to fostering supportive environments and her expertise in both direct client care and professional development help make AWC an innovative and progressive team of skilled and supportive experts, dedicated to positively impacting the mental health landscape for all. And with those introductions, I will turn it over to the two of them.
Thank you, Pam, and hello, everyone. Thank you for joining us. I am Colleen Musso, and I acknowledge that I live and serve on the traditional, ancestral, and unceded territories of the Haudenosaunee, the Anishinaabe, and the Mississaugas of the Credit First Nation. And I'm committed to honoring and continuing their relationships with this land. I also recognize that acknowledging land and place is only one small path toward truth and reconciliation. In my practice as a psychotherapist, I strive for an ongoing commitment to create spaces where truths shared by everyone are honored and where honesty about all things, including topics around death and dying and illness, are really quite central. My hope is that that really comes through in the pieces that I can add to the discussion today about medical assistance in dying. Andrea and I first met about 12 years ago when I started working at, we were both working as children's grief therapists at a program connected to the team at the Temi Latner Center for Palliative Care at Mount Sinai Hospital in Toronto. And it was through this role that I first recall conversations among these teams of palliative care physicians at our weekly rounds, expressing very polarized feelings around MAiD before it was even called that in Canada, before it was legal. I remember physicians struggling with some of the implications that this may have for their patients, their practice, their conscience, their spirituality, and their ethics. I also recall myself supporting children around one of the first people in Ontario to receive MAiD. This was back in 2017. And I'm going to admit that I really kind of fumbled my way through, and it wasn't totally disastrous, but I've certainly learned a lot since then. And at that time, I was drawing mainly on the work that I was already doing in end-of-life care to support families around including their children, to help prepare them and offer agency around their wishes to be included, all of it, which still feels very much a part of how I continue to show up and support my clients when someone is dying. I lean on the collective wisdom that I keep tapping into among my colleagues. Andrea and I run a group practice where we have almost 40 grief therapists working across Ontario. And we've had some incredibly insightful input from them as well around their work in supporting clients around MAiD. So I'm drawing on that today as well. So I'm really quite grateful to have this space today to share this collective knowledge and some really key considerations for us as RPs. So when I think back, it was 9 years ago that I first supported a family around MAiD. And we continue to see that the conversations, the legislation, the criteria around MAiD is still evolving. So I lean on the clarity and the structure that does exist now, as unclear as some of it may be. I think we have to focus on what do we know. And so Pam provided such a clear overview of the structures of MAiD, of the application and the process of MAiD, and the standards of practice within the CRPO. So I won't be redundant in that. But we will be sharing in a link some of the statistics connected to MAiD at this point that have been provided by Health Canada and StatsCan, representing how many of the deaths in Canada have been via MAiD, the gender divide between who's accessing MAiD, and that sort of thing. When we're talking about key ethical principles, we've got our, ethical considerations around autonomy, the dignity, the do no harm, and the justice in the name of our clients. MAiD really highlights our need as RPs to be balancing our clients' rights within our professional responsibilities. And something that I want to establish is that in our practice at AWC Grief Support, we speak openly and honestly and often quite directly about death and dying. And we work really hard to create spaces where our clients can do this safely as well. But we are not in a position to encourage or discourage our clients around MAiD. We want to ensure that our clinicians have the skill to navigate these conversations. We invite that contemplation and curiosity about MAiD, and we know which resources to offer and share with our clients as appropriate. But we rely on clearly recognizing our role as psychotherapists and the boundaries of that role as well. So in terms of the legal requirements for mental health professionals, again, I'm glad that Pam really referenced that, and quite specifically within the standards of practice within the CRPO. When I think about it, I think about the key obligations for our psychotherapists, that when MAiD is raised in therapy, that we have an understanding of the criteria and the referral process. So the criteria for MAiD will most certainly continue to change and evolve over time. And so part of our practice currency will be staying up to date with these changes as they come through. And when it comes to MAiD and the mental health diagnosis, I think this is worthy of discussion and consideration because of the complexities with our clients with primary mental health conditions. Pam was talking about Bill C-39, which has the inclusion of mental health criterion in MAiD, but that has been tabled until 2027. So for today's conversation, it's simply important to know that, and simply important to know that as you might be walking through that with your clients who might be curious as well. So let's first think about the considerations for our role as psychotherapists. Firstly, we rely on self-regulation in our profession, and this means as RPs, we will seek supervision and consultation in any scenario when we need to ensure the appropriateness of our roles. In terms of a clinical role, our client may be the person who's dying and knows nothing about MAiD. They may be applying for MAiD, whether they're actually eligible or not. They may be dying by MAiD. They could be a client who wishes to die by MAiD but doesn't want to share this with their family or friends, or maybe they belong to a family or religion that may not recognize this, or they may carry tremendous shame around it, which can complicate the narrative around their death. They could also be a family member of somebody who has died or is dying by MAiD. So we're going to have to consider some of the support needs in those folks as well. And so amidst this range of clientele, it's important for us to consider, how do we continue to show up as the psychotherapist, maintaining clarity in our role and operating in the best interest of our clients. So within this clinical role, there are also some assessment considerations. And what I mean by that is using your role to help your clients explore the underlying factors that might be driving a MAiD request, such as depression, although on its own is not an eligibility criteria at this point, but it's actually a really common driving factor in a request for a death by MAiD. It could be your client's relationship to pain. It could be their belief systems around not wanting to be a burden to others. It could be their own fear of dying or their sense of loss of control. It could be their own fear of death itself. So to me, this feels like the pocket of the work that we might be doing directly with our clients around MAiD that has more indirect influence on the application and the assessment involved in MAiD itself. Another major part of our role involves the clinical discretion around confidentiality. Now, I'm thinking of how challenged this piece is when we're supporting a client who might be curious about thinking about how or about dying by MAiD, but doesn't want anyone in their family to know this. So we have to remember that this is a really personal and sensitive decision for our clients. And in order for somebody dying to discuss their death by MAiD with their family, they first need to have the skills and support to discuss their own death with others too. So as RPs, we're very likely to be in this situation to play that supportive role. And Andrea is going to share some ways to help clients open the conversation and to work with wherever they are at. It's also important for RPs to recognize our role as part of the multidisciplinary team. So understanding the scope of our practice, the limits of our roles can really help us to collaborate with the other healthcare providers and MAiD assessors and MAiD providers. And I want to emphasize that we are a part of the client's circle of care. And as RPs, we have every right, with our client's consent, to be reaching out to connect with other members of their medical team and to be considered a member of the care team. And in my experience, playing an active role in the circle of care also helps me continually reestablish the limits of my role as well. In terms of ethics, this raises so much importance on the ethical boundaries we uphold in our discussion of MAiD with our clients. This means staying within our professional limits while offering a supportive space for clients to process complex emotions and decisions around their own mortality. We continually need to be recognizing our power and our privilege in the relationship with our clients, appreciating their vulnerability and the possibility of our influence on their decision-making. We really want to keep this in check, which comes from our own reflective practice of understanding ourselves, our values, and our biases. And at the foundation of our role, regardless of the modality that we're trained in or our practice site, we should all be working to support our clients' autonomy, which means we operate to respect our clients' rights to make informed decisions about their care while providing thorough and compassionate support. We are not the decision makers, and I can't emphasize that enough. Our role is as a supporter, but not the decision maker. We will be the most supportive and present when we maintain a strong sense of ourselves and our own reactions to whatever is coming up with our clients. So in the words of Dr. Dan Siegel, we have to name it to tame it. So let's name the discomfort and the anxiety that seems to be driving a lot of these conversations around MAiD. We see this in all angles. I'm seeing it a ton in the media right now. There's political debates, and it might be even part of what brought you into the webinar today. Using myself as an example here, it's been many years now where I've been working around death and dying, and I still feel quite intimidated around this topic. So how do I keep it in check? I mean, I find comfort in those structures that exist around MAiD and knowing that there's a fulsome application process, there's thorough assessments, decision-making committees. And I also have to name that discomfort that I have, and I get curious about it. I wonder, what's it all about? What does this discomfort need? Sometimes it's more information. Sometimes I feel like I'm not up to date with, the latest criteria or changes to an application process and that sort of thing. Sometimes it's validation. So naming that, maybe it's connection to others who are doing this work too and navigating similar situations with their clients. A lot of times it's just self-compassion and permission for this to not be perfect, and know that I'm showing up with my heart and doing my best. So it's possible to get comfortable with that discomfort and exist in this space with that all being okay. So I want to say that I work pretty much exclusively around death and dying. And I acknowledge that all of my clients, whether they're curious about MAiD or dying by MAiD, have had a terminal illness and death was foreseeable. So these are those track one MAiD deaths that my clients have never really been in that gray zone that makes a lot of us feel really quite unsettled. So I'm talking about the folks that are also getting a lot of media coverage. They may be suffering with chronic pain or permanent disability, but the death is not foreseeable, and they wish to end their life by MAiD. So their suffering can be disenfranchised if their application to pursue MAiD is declined, and yet when it's approved, it can feel like the systems that we're all part of have somehow failed them as well. I think it's important for us to establish what's the difference between suicidality and a death by MAiD. Both suicidality and a desire to explore MAiD involve thoughts about death, but they differ significantly in the intent, in the context, and the approach. Suicidality often arises from acute emotional distress, feelings of hopelessness, or mental health crisis, where the individual may not see a viable path forward and may not be able to consider the long-term impact of their actions. In contrast, I think about MAiD as a highly organized process, that it's an inquiry that usually comes from an individual that's facing that irreversible suffering due to terminal or chronic illness. The decision requires a lot of this executive functioning in order to be able to be deliberate, involves careful reflection, assessment, and the fulfillment of other legal and ethical criteria. It's really designed to support someone's autonomy at the end of their life. For clinicians, it's essential to be able to recognize these differences so that when we're sitting with a client, we can discern, am I sitting with somebody who's suicidal and we want to move into that safety planning or crisis intervention, or are we exploring this from a contemplative standpoint where we're getting a little bit more curious around what does this mean for my client, and how are we going to move forward with some resources and some information. So I cannot emphasize enough, you do not have to be an expert on this topic, but we should all have access to the resources that we need at our fingertips to help our clients as they get curious about MAiD. The other piece that I'll leave you with is the encouragement to not do this in isolation, to seek skilled consultation and supervision, to care for your heart, to care for your conscience that can so easily become exhausted in all of these considerations around clients who might be considering MAiD. So I'm going to pass you over to Andrea now, who's going to share with you some really practical strategies and some resources to help you navigate with your clients.
Thanks, Colleen. So I'm coming today from Guelph, Ontario, which is the traditional territory of the Mississauga, the Credit First Nations of the Anishinaabe people. And when I reflect on my own process of learning more about the stories, the history of this land, it really, I realize there's a lot of parallels to also how I conduct myself when I'm supporting clients who are either contemplating, their own death, considering a medically assisted death, or are family members of someone who's dying. And throughout, when I reference family members, I'm really speaking to chosen family, anybody somebody considers family. And, those parallels are really discerning, when is my job to hear the stories, learn about the history of the land, as horrific as it may be at times, hear about the incredible suffering of my client, who, as Colleen referenced, many of the people that we work with, I'd say the vast majority of people that we work with who are considering a medically assisted death is reasonably foreseeable. So it's usually people who are seeking out MAiD through track one. And then discerning, when is my job to take action, right? Whether it's through, the calls to action with truth and reconciliation, or actually I realize that the client that I'm supporting, there's an information gap. And I need to help fill that information gap, or help them even know maybe that MAiD is an option for them, because that's not a given across Canada right now. And so I really encourage, as you're doing this work and as you're supporting people, to just sort of keep those pieces in mind. When is my job to listen to the stories, to bear witness to the suffering? When is my job to, validate how hard this actually is? And when is my job to take action to maybe fill an informational gap, right? To give a resource. We've included a number of resources, and everybody will get these slides, as Pam said. And I think, an important thing for me in this process has always been recognizing the need to get comfortable with my discomfort. And no matter how many years I work, both as an RP and a registered nurse, there's always situations that I end up in where I'm like, ooh, this is pushing me out of my comfort zone. And one of the things I've really come to learn is, just because I'm not in my comfort zone does not disqualify me from being able to be a skilled helper or skilled supporter of somebody who's navigating, whether it's chronic illness, whether it's the end of their life, or any type of really difficult situation that brings them to us as registered psychotherapists. And, I think one of the things that I've really come to learn, again, both in my role as a nurse and as an RP, is that, it's not a given that people have clear understanding about their underlying condition, about their prognosis. I really make it a standard of my practice to ask people when I'm working with them, or maybe I'm working with one of their family members or a close friend, I'm wondering what your understanding of your illness is. I'm wondering what your understanding of your prognosis is, right? Do they have as much information as they need? Do they want more information? Or have they just come out from, an appointment with an oncologist where way more information on them got dumped than, they actually wanted? I love the work of Atul Gawande in his book, Being Mortal, but really recognizing that quite often people are, going into healthcare, meetings and things like that, and are coming out really not clear about their prognosis and about their condition and the implications. And that's why I think we're so, we're really ideally positioned as RPs to have bigger conversations exploring this. Right? This piece of grief literacy is huge, and it's an exciting time in Canada too. It was last November, a year ago, when the first time the national government actually dedicated money, not a ton of money, but some money, to enhance grief literacy across Canada. How do we show up for one another? How do we support each other when we're grieving? Right? What does that look like? And quite often, if we're supporting somebody who's contemplating medical assistance in dying, or has somebody in their orbit who is, there's going to be some grief there. And one of the things that Colleen and I know I speak again for our whole team in our approach, is really to take a non-pathological view of grief. Right? Quite often when it's so hard, people will say to us, I didn't think it could be this hard. Am I doing this wrong? And a lot of times our approach is one of validation. No, it is this hard. And that's okay. And clinically, we need to have the skill too, to know, actually, is there, an underlying depression or something like that? Well, we can't diagnose. Maybe we need to get them to somebody who can. And Colleen spoke to some of, differentiating those pieces as well. I've included here, and this is not meant to be scripted at all, but it's one of the questions again, a standard in my practice to ask people that I'm working with, really informed by the work around cultural humility, which I just love, but is just early in the work together, even maybe on intake, is wondering and asking, are there things that I should know about you, your family? Again, I really sort of broaden that view of family. Your values, your cultures, your beliefs that would be helpful to me or helpful to you as we're working together, or as I'm supporting you. Right? And I've included here, a great tool really designed for healthcare providers. So these, as RPs, we might not be having all elements of these conversations, but I do include it here with the link as well, because it's really been such a wonderful resource to me in terms of just engaging in conversations with people who have a serious illness, right? And being able to understand or get a sense of their understanding of their illness. I love that it starts with even asking permission to enter into this conversation with them. You know, again, assessing that informational needs. What's their understanding of their prognosis? So I'm not going to go into it in any more depth here because it's a resource that you'll all receive. Some of you are probably very familiar with. But I think the language is really wonderful and gentle, and it allows us to enter into these conversations, which are often precursors to having conversations about medical assistance in dying. We really want to know what their existing level of understanding is about their condition. And then I think one of the pieces where, again, as RPs, we are really ideally positioned is to deeply explore people's suffering. You know, I often reflect back to my time as a bedside nurse, and medical assistance in dying wasn't legal then. But certainly those conversations came up. I can remember years and years ago, people saying to me that they wished that this was an option, right? Or that actually sometimes we treat our pets more humanely than we do adult humans at the end of life. And quite often, you know, these conversations would come up. As a nurse, I would often find it would be 2 a.m., the vulnerable hour, where the biggest worries people would often express. And sometimes I was able to have bigger conversations about it. And sometimes I had like 3 minutes in that room till I had to go and hang somebody else's chemo or whatever the situation was. And it's not lost on me that now, operating as an RP, you know, I often, granted I'm in private practice, but have 50-minute windows when I'm entering into conversations with people. And that does give us the opportunity to really explore that suffering with people in a way that for most people, they probably don't have a lot of opportunities to do that with other people in their lives. Right? And that's where, again, I've included some of the sort of conversational pieces that you know, the way I enter some of these conversations, not meant to be scripted or anything else. But I want to know if I've got a client who's, you know, talking about a lot of suffering or maybe wanting to have more control about what's happening in their life. I'm going to wonder with them. I love that language of wondering because I find it's a really gentle, non-judgmental way where people can pretty easily say, nope, I'm not thinking about that. Or yes, I am. I'm wondering what your understanding is about the options that are available to you right now. You know, and that's where, again, we want to be informed enough about medical assistance in dying and who it's available to, that we're not bringing up the possibility of a medically assisted death to somebody who might not even be eligible. That can actually cause more suffering. Right? But if it is somebody we know that they are likely to meet the eligibility, even though we can't assess it ourselves, I'm just going to wonder with them, you know, what's your understanding about your options? Sometimes people are very quick to say, well, I am thinking about a medically assisted death, or I'm wondering about this. Do you know about palliative care? Right? That's not a given across Canada as well. There's huge gaps for people being able to access, you know, really good care at the end of life as well. So I want to find out what they know about, right? If they're not referencing palliative care, medical assistance in dying, therapy, you know, different options that may be available. It might not be necessarily them, but to their person, you know, who they care about, who's dying or whatever the situation is. I want to let them know, you know, do you know that medically assisted death is legal in Canada now? Do you know what palliative care is? Sort of lay out some of the options and know where to resource them. Right. And I think a really important thing too is sometimes when people are sharing their wonderings, their worries, I find that we can be quick to feel diminished when we don't have the answer for them. And I think it's a really important reframe for all of us in our information obsessed society where we're pretty used to, if we can't find the answer, Google can. When we're encountering people who have chronic illness, who are, you know, dying, or have had someone die, or just, you know, encounters with our mortality, there are some times where we're not going to have the answer. And that is hard. I can't tell you how many times that comes up in my therapy sessions of working with people. Just making space to wonder about the big questions or to not know. And that's where, again, clinically, we need to discern, okay, is my client wondering about something that actually this is an informational gap, but if I connect them to the right person, they'll be able to help them navigate that? Or is this one of the big existential pieces that no one's going to have the answer to? And so my job is to create that space. And I'd always rather people have the opportunity to wonder together than to wonder alone about the unanswerables. And that's where I come back to again. I mean, this is always playing out in my mind in my sessions, because sometimes I think we're quick to want to fix when we witness suffering, or distract sometimes, even more so I find can be heightened in our personal lives. But is my job right now to validate? Do I need to take action? Do I need to resource? Do I need to help fill in that information gap? Or is my job, and sometimes I think this is the most challenging one of bearing witness to suffering right now? And, you know, I mentioned the fix-it trap. I love Elizabeth Costin's work. She's a social worker at Victoria, I believe. But she really looks at the tendencies. I mean, I think this was largely focused, you know, in healthcare, but I also see it happen in therapy all the time and in our personal lives. The tendency to shut down conversation when somebody is expressing or sharing their sufferings or their wonderings or their unanswerable questions, right? And how quick we'll often be to try to fix it or tell them they're so strong, not realizing the shadow side of that is, I can't tell you how many clients have said to me, I am really hesitant to share my vulnerability and my hardest moments with those people in my life who have called me so strong, because they only do so when I'm totally contained, right? And it makes me feel like when I'm entering into my suffering or my vulnerability, that it's a weakness. And that's where I find a lot of supporting people around grief and loss and mortality is providing a reframe. And again, you know, not pathologizing grief or suffering or having unanswerable questions and validating when it's hard. And for those who want it, again, resourcing them so they know what their options are. They're able to make informed decisions and navigate that. So I'm just going to include, you know, a couple of quick pieces here too around supporting children, because this comes up in my sessions all the time. In terms of, you know, do we tell the children it's a medically assisted death or that we're considering a medically assisted death? When do we tell the children? And, you know, to back up for a moment, I think it's really important that just to acknowledge the fact that unlike 15, 20 years ago, we now have a large body of literature that is super clear about the fact that if kids have somebody in their life who is seriously ill or dying or died, they benefit from honest and inclusive information. And MAiD is no exception to that. So our team is often encouraging families, you know, you don't have to wait until the day is chosen for a MAiD death or that you know it's going to happen for sure. Sometimes we don't know it's going to happen for sure. Even when we're talking to families or coaching them and talking to their kids about a medically assisted death. I'll also I always add the caveat that, you know, your grandpa might be planning on having a medically assisted death and he may change his mind. Or he may die before his day comes to have a medically assisted death. It doesn't have to be absolute in order to include kids. But certainly we want to find out, you know, do they want to be involved? Of course, the person who's having the medically assisted death gets the trump card with that. So I'm always exploring that before I'm opening up options to children or encouraging their families to do so. I'm really careful with the language of choice, particularly for those folks who are choosing, you know, who it's a track one medically assisted death, where I really like to help kids understand that your person's not choosing to die, if this is true. Your person is choosing when and how and maybe where to die. So before closing us up and opening up for questions, I just want to include, again, an example of how myself and many of the folks on our team sort of would coach a family to talk about medically assisted dying with kids. Again, emphasizing the piece that we'd always rather kids learn about these things from the adults closest to them There's not a too early to have this conversation, right? If somebody is dying in their life or is considering a medically assisted death, or likely to have one. And again, this isn't meant to be scripted, but typically the language I use is that in Canada, when someone has a illness that will cause their body to die, they can wait for this to happen or ask a doctor or a nurse practitioner to help their body die. The doctor uses medication that stops the body from working, and it's done in a way that's not painful. Right? In Canada, this is called medical assistance in dying, or MAiD. And then I'm checking in about the kids' informational needs. Some kids want to know safeguards. Some kids want tons of information. Some want very little, right? This is where, when possible, I've had many kids who I've set up a meeting where they can actually talk to the person who will be administering the medications for the medically assisted death or the assister if they want to get more information, hopefully with a caregiver, a parent, in the room with them for that conversation too. And I've had some teens who say, no, I want to have that conversation by myself without my caregiver there. And so a key piece, and this is both for kids and adults, when we're supporting people, because I recognize this is the reality for many people, probably statistically more so than supporting the person is dying or contemplating a medically assisted death themselves. When I'm supporting people who have had someone in their life die from a medically assisted death, I want to know what's their narrative, right? Or if somebody asks them how did their person die, how are they going to answer that? Do they want to say they died from ALS, cancer, a medically assisted death? I don't want to talk about it, thanks. Give them options, because those can be really emotionally loaded questions that inevitably people are going to have to contend with, right? As psychotherapists, we want to have a radar too. Are there stuck points? Are there pieces that the person's going back to? Maybe has nothing to do with the medically assisted death. Maybe it's that day they first got the diagnosis in the first place, but are there stuck points that we need to help support the client around? Does the client maybe need some trauma processing support as well? And certainly, is the individual or the families are aware of the MAiD resources that are available to them? And there's a number of really great resources that are available. And so we've included them in this webinar as well and in the handouts. Really one of the most powerful things, I think, and sometimes the most challenging things that we have to do in this role is this piece about bearing witness and really deeply showing up for somebody who's sharing. It may be suffering, it may be existential angst about, what they're experiencing or they're approaching death. But that's where, again, I can't emphasize enough that RPs are ideally positioned and trained to be able to do that. And even with that, it is hard work. And so just to emphasize the piece again, that Colleen shared as well, lean into your colleagues, lean into community, whether it's through supervision, informal groups. Such an important piece is us being able to all support each other in doing this work. So I'm going to pass it back to Pam. I can see a number of questions have come through, and we just want to open up and take those questions.
Sorry about that with my mute. There was a question posed about navigating a client who has expressed a desire for MAiD, but also has contemplated suicide, and how to navigate that duality in clients.
Colleen, you want
start?
that?
You can jump in. Yeah, I think certainly even the exclusionary criteria within MAiD wouldn't include that as a viable applicant. So our work as an RP would include stabilizing. You're in that sort of recognizing the suicidality, naming it for that, even if there's oscillation between could I die by suicide via MAiD, we're going to hang out with that suicidality and find the resources to safely plan, to crisis manage in those moments, so that we are really doing some life affirming work as opposed to the work around, exploring somebody's death via MAiD. I think until somebody is actually, when somebody is stable, they are in a different position to actually be able to explore MAiD as a viable option for them. But when we have that active suicidality, that as our role as an RP is to respond to that entirely.
We also had a question come in specifically for Andrea, noting that you are, of course, a registered nurse, but for those who are RPs and not RNs, they feel that there is a fine balance when discussing medical diagnoses, as obviously RPs cannot provide a diagnosis or medical information. How can RPs assist in the provision of information without giving medical information?
Yeah, it's a great question. Thank you. I should have added the caveat. I'm a very rusty RN, and it's been many years since I've been a bedside nurse. So, when I'm doing my work as a psychotherapist now, like I don't have any more insight into the background of the illness, the prognosis than any other psychotherapist. And that's where I really lean into that language of just wondering what the person's understanding is. I have a pretty good understanding of oncology because that's the work I did, but there's a lot of illnesses that I work with that I actually know very little about. So I'm really leaning into that. Does that person feel like they have clarity from their healthcare team? Right? Does that person need some coaching around, if they're not feeling clear, right? If Tuoga one day spoke so beautifully about how despite 150 years of collective medical experience between him and his two surgeon parents, they could not understand what the oncologist had said about his dad's prognosis when he received his cancer diagnosis, right? So if there's any lack of clarity, I'll sort of give some advice. I'll give some, guidance about going back and maybe having more direct conversations with medical professionals, because that's where the information does need to come from. Even sometimes I'll encourage and say, I said to someone last week, because she was like, I have a lot of anxiety and I do better with more information. I said, I wouldn't hesitate to share that with your physician and say, I'm feeling very confused right now about my prognosis, about my illness, right? About how long you're expecting I may live, or is this even potentially curable? Be really clear in asking those questions. But I think it's a very important point. It's as RPs, our job is not to be sort of laying out all of the treatment options or giving in-depth information at all about medical diagnoses. And that's very much the way I operate right now, because I'm not working on the front end of healthcare in the clients that I'm supporting. And so I'm exploring, I'm getting a sense, do they have clarity and do they need help getting more clarity?
It looks like we have just 1 minute left, so if I can just squeak in one last question. There was a question about where RPs could find consultation and connection with peers so as not to do this work in isolation. Are there any suggestions from either of you?
Colleen, over to you.
Yeah, I really it would involve some connection to some of our associations, so the OAHMP or CCPA, or some of that peer supervision type group. HPCO, so the Hospice and Palliative Care Group of Ontario, is a grouping of kind of multidisciplinary professionals, as well as patient-facing or directly for families and individuals themselves as well. They have key interest groups. They offer education. So I'd say through some connections with some of these networks, you're going to find some peers that you could connect with. I really benefit from just kind of like asking, can I join some grand rounds that are being offered through hospice, through palliative care teams? They generally don't mind having an extra person there. Sometimes I'm contributing as well, some case presentation or presentation itself. So becoming a bit more friendly and joining as an observer, but also as a contributor into some of these spaces. Andrea, do you have any in our current resources that you want to share?
Well, I think a couple things to consider is virtual hospice is doing monthly, like they've got adult grief chats where it's a free resource and people just show up and can ask questions, including questions about medical assistance in dying. And there's skilled therapists there who are answering the questions. Colleen and myself and our colleague Nicola do the kids grief Q&A. I know we did it on Tuesday. This is free too. I think the main question we had emailed in lot on Tuesday was a medically assisted in dying question about how to support kids. Right. So there are some great resources there. Again, we'll get these slides out. There's a lot of resources in there. But I also informally wouldn't hesitate to just sort of reach out to peers and sort of figure out, like, can we even create informal supervision groups where we show up for, people who are doing this work? You're welcome to reach out to our team. We've always got supervision groups that are running as well, both trauma informed, grief informed. Yeah, really, I mean, I love the question. And there are some resources out there, and sometimes we have to create them too and say, you know what, we know a bunch of people who are doing this work. Let's just start meeting once a month and lean into each other as we do it. I know I can see that there's lots of really good questions here. And I know that we're also up against our time. And so, we're going to make sure that these resources, which I hope will respond to some of the questions, this might need to be more of an ongoing conversation as well. But we'll make sure that these resources do get out to everybody. I also just want to close everybody off with this quote, which I think is such an important one to come back to this sort of non-pathological view of grief as well, and just really being able to validate for people, like, this is hard, whether you're the supporter, you're the person navigating it or grieving, somebody else's illness, death, consideration of MAiD. Grief feels like a psychosis. It's implosive, explosive, arbitrary, unjust, but it's basic to the human condition as love and joy. So Pam, thank you, for making this possible. I'm going to hand back to you, and my hope is, we'll find ways to keep this conversation going, because I can see such great questions coming through and everything as well.
Thank you so much. I really want to sincerely thank both Andrea and Colleen on behalf of CRPO, but also on behalf of all the registrants here today. We very much appreciate your guidance and insight. Just a quick note on CRPO's end, I understand that there were a number of questions we were not able to get to today. We will do our best to answer them in a follow-up Q&A document that will be distributed broadly. We will also be providing the slide deck as well as a transcript of the conversation today. Again, that will be distributed broadly, and a recording of today's presentation will also be available on YouTube. I know we've gone a couple minutes over, so I want to thank everyone for their participation today, and hopefully we haven't kept you too long.
Thanks, everybody.
All right, take care.